Okay.
From which fuck? The Boogie Down Bronx, baby. WNBA All-Star, all-time assist leader, and just all-around good people.
This is a world where everyone watches WNBA.
Coaches.
Yeah. That's where everybody watches WNBA, and a person experiencing a psychotic episode requires the attention of the entire emergency department as a novel occurrence. And again, what is he doing? Where are the other patients? Why isn't he rounding on the neurology service if he works in that? And why do they still have an old school X-ray light up box to look at MRIs? Everything has been on computer for the past 25 years. Again, I'm not sure why detailing the exact nature of the dragon hallucination is important for diagnostic or treatment purposes. So you can get urine drug screens and blood alcohol tests as a point of test. But see, they didn't have anybody to run those point of care tests because everybody was so fascinated by someone in the ER with psychotic symptoms. This is going to turn out to be epilepsy, I think. That's my prediction. You can have sleep onset seizures. Sleep is epileptogenic. I have seen some people who had weird epilepsy in their sleep that presented as psychiatric symptoms first. But again, would not have been a contraindication to gallbladder surgery. So derealization and depersonalization can happen with stress and severe anxiety. They can also happen sometimes with epilepsy. I don't know if they're going to deter. I would also wonder what's going on. Does she have delirium because she has an untreated? I mean, if this is a purely elective gallbladder surgery, they can send her home and she can, come back. But if it's something that needs to be done right away, then why aren't they thinking, well, maybe she...
So they just decided that this was definitely neurologic because he has insight into the fact that it's not real.
That's absolutely wrong. There are plenty of people with psychotic disorders who have insight that it's not real. It's not necessarily as common with like the first episode of something. Like I've certainly taken care of people with schizophrenia who told me, the voices started talking to me again, so I knew I needed to come see you and have you adjust my medication. And the insight is also not all or nothing. A lot of times people say intellectually they understand that it can't be real, doesn't make sense, but in the moment when it's going on, like it feels real, right? And I've also seen plenty of people with neurologic causes of psychosis that have zero insight that it's not really happening.
Did you have to learn to do a spinal tap?
Yeah, I have done them. Called the spinal cord, so I don't know if that's a throwaway line or like a checkoff.
Right, it's got to be connected.
I think they just are trying to characterize her as someone who knows about drugs.
It is. So think the dorsal columns of the spinal cord, you can have loss of proprioception. But again, these things usually cause other deficits. Being totally fine otherwise, walking, talking, full strength, no deficits, and total loss of proprioception would be very, very unlikely. I never want to say anything that's 100% impossible, but it's very. I think all you would need to say is we've ordered MRI of the spinal cord. We're going to take a look. You don't need all the rest of the drama. Usually they are very, very, very strict about who goes in the cadaver lab at a medical school. You can't just bring your son down to start impromptu dissections. Like the cadavers have to be accounted for. They have to be treated with respect. They also have a limited number. And you don't want to have like random people start carving them up and then you don't have them for the medical. Do they only have 2 patients in the neurology service? Like, what about the people with normal problems, like non-exciting problems, like, stroke, regular seizures, intractable migraine, MS exacerbation?
They send them to a different hospital.
Yeah. I mean, when I did my neurology residency, like 75% of what we did was stroke. People with boring deficits, you still have to take care of them and help them. See, are they going to people's houses again? How do they have time to do that? What about the other patients? Like, we would usually have like 30 patients on our neurology service. Many of them, well, again, maybe not having exciting deficits, were seriously ill and needed ongoing care. People in the ICU, people with, unknown causes of bizarre white matter problems, stuff like that needed ongoing work, new people in the why do they have the neurologist running the code? Like, very sadly, she passed away because the neurologist was running the code instead of the code.
We flushed her.
It means if someone has a cardiac arrest or stops breathing or something, there's people, it's a specialized team. Usually it's ICU doctors, maybe emergency medicine, ICU nurses. Like, it's a very structured thing. People have roles, they have the crash cart. And usually it may rotate among, like the different ICU docs or, internal medicine sometimes. Now, if you were there when the code happened, even if you're a neurologist or psychiatrist or whatever, like, you have to start, but you would very quickly call the code team and, you would want them to take over as quickly as possible. And they can do things like intubate the person, which most neurologists, something we would know how to do. I don't really see a reason to get better. I think they need to find out what caused her cardiac arrest. Why did they wait all this time to do an MRI? Yeah, why didn't you do the MRI before you went and looked at his apartment? I can understand he got the non-con head CT as part of the ER protocol, but like, as soon as he's, admitted to neurology, and today, actually, for new onset psychosis, an MRI is standard of care. Yeah, well, so in the ER, they probably would just do a non-contrast head CT. That's not as sensitive, but it's because if somebody didn't have like a, bleeding or something like that, you'd want to see it right away. MRI takes longer, but I can't believe that they didn't do it all. That would have been like the second thing to do. Like, before you go break into his house to look for dragons, I would have just done an MRI. And actually today for new onset, it's easy to get attached when you apparently only have 2 patients. Still haven't looked at her spinal cord. Maybe the real spinal MRIs were the friends we made along the way. And also, they fairly routinely do trials of people off ventilators to see if they're starting to get their ability to breathe back. And obviously, you do it carefully. Usually, you have like the ICU doctor or the respiratory tech or somebody there, the neurologist, or at least not just the neurologist. But it's not like this dramatic thing like, oh, she'll just die if this doesn't work out. Like, you do trials off vents, and yeah, and it's just, and the other thing is it's not all or nothing. It's not like either you're breathing totally on your own or you're intubated. They can do like, bag mats, ventilation, but this worked. And now she's walking by herself with not anybody standing next to her in case to catch her if she falls. Yeah, but you can believe, usually you have trouble walking, balance problems, people saying they feel unsteady on their feet, like maybe having falls because they couldn't feel where their feet were. That would be much more common than going from being fine, having a weird dream, complete inability to move and breathe. And again, what about the MRI? Shouldn't they check to make, before they have her up and walking around and possibly falling down, like, make sure she has like an, unstable, problem in the C-spine or something like that? I think it depends on whether it's causing problems. There's different surgical treatment. You start with the fundamentals, like getting an MRI to look at the person's spinal cord if you think they've had a complete loss of proprioception. But see, that makes it easy. You come up with this dramatic storyline, but you don't have to have a plausible etiology. You're just like, well, that's will never be.
Not discussing with me ever.
Yeah, this is the least busy hospital in the world. Why is the chief of medicine like following up on every single of the neurology cases? To be fair, when you only have 2 neurology patients in the whole hospital, it's probably easy to follow up on them.
She actually was.
Gallbladder. Did she ever get her gallbladder?
I don't know, but it was the chief of medicine that was supposed to do the gallbladder surgery too.
Yeah. I assume they mean chief medical officer. Chief of medicine is the chief of the internal medicine service, who is not a surgeon. So they did say chief of medicine, but I think they mean chief medical officer. But again, they don't understand the boundaries between different. See, I don't think it's a bias to say this could be substance related. I mean, that's in the differential diagnosis. If you stop there, that's a problem. But they went ahead and ordered the MRI, and they found the vascular malformation. Like, it seems pretty reasonable. Again, the problem was going to search his apartment before just simply doing some brain imaging. So when you only have 2 patients, you got to fill the time somehow. Yeah. This is a genius device for medical shows. Make up any random implausible scenario you want and then be like, well, we'll never know what it really was because we didn't do any workup and we also didn't take out her gallbladder. That was the whole reason she was in the hospital to begin with. But, she learned to believe in herself.
That maybe she fixed the gallbladder problem by believing
Exactly. She just believed that her gallbladder was free of stones and blockages and sludge and infections, and that was all